Alright, let's walk through type 3 hypersensitivity. We think about this the same way every time. What is the immune system building? Where does it deposit? And why does that deposition cause damage? So the core concept is that type 3 hypersensitivity is immune complex mediated. An immune complex is antigen plus antibody, usually IgG. Once complement binds, we can picture it like this: antigen, antibody, and complement. The key problem is not that immune complexes form. The key problem is that they circulate, then deposit in tissues, and once deposited, they trigger inflammation. So the clean chain is immune complexes deposit, complement activates, neutrophils arrive, and then neutrophils release lysosomal enzymes and causing tissue damage. So immune complex deposit, complement, and then neutrophils arrive, lysosomal enzymes released and causing tissue injury. Because deposition commonly occurs in small vessels and filtration structures, type 3 hypersensitivity is strongly associated with vasculitis, glomerulonephritis, or multi-system inflammatory disease. Let's talk the step-by-step mechanism. First of all, immune complexes form in the blood. We have antigen in the body. This antigen could come from infection, drugs, foreign proteins, or autoimmune sources. Antibodies bind to these antigens, forming circulating complexes. IgG is emphasized because it forms circulating complexes easily and it activates complement efficiently when bound to antigen. This is important. When we see immune complexes and complement activation, think about IgG. The next step is that complexes deposit in tissues. These complexes circulate and then get stuck in small blood vessels or high pressure filtration sites like the glomeruli. Okay, why do they deposit? Because immune complexes can be the right size to get trapped in vascular structures, and sometimes the immune system cannot clear them quickly enough. Once struck, they become inflammatory triggers. And the next, there is complement activation. When immune complexes deposit in tissue, they activate complement. Why does complement matter clinically? It amplifies inflammation, it attracts neutrophils, and it gets consumed. This is why many immune complex diseases show low C3 and low C4. Low complement is a huge clue for immune complex disease. Next step is neutrophil recruitment and tissue damage. Complement attracts neutrophils to the site. Neutrophils attempt to clear immune complexes, but here's the problem. The complexes are stuck in tissue. Neutrophils cannot phagocytose them properly. So what happens? They release their contents outward. They release lysosomal enzymes, reactive oxygen species. So these substances are meant to destroy microbes, but now they damage host tissue. That is why we see endothelial injury, vasculitis, kidney damage, and tissue necrosis. Again, let's repeat the chain: immune complexes, and then complement, and then neutrophils come, lysosomal enzymes released, and causing tissue injury. This is type 3 hypersensitivity reaction. So what type 3 looks like clinically? Because immune complexes can deposit in many tissues, the manifestations are often systemic. Common findings include fever, malaise, arthralgia or arthritis, rash or urticaria, proteinuria or hematuria, or vasculitis. When you see multi-system inflammatory findings, always ask, could immune complexes be depositing somewhere? There are must-know hypersensitivity type 3 diseases. Classic examples include systemic lupus erythematosus, SLE, rheumatoid arthritis, reactive arthritis, polyarteritis nodosa, post-streptococcal glomerulonephritis, IgA vasculitis. Let's repeat the classic examples: SLE, rheumatoid arthritis, reactive arthritis, polyarteritis nodosa, post-streptococcal glomerulonephritis, and IgA vasculitis. Let's talk about serum sickness, which is the prototypic systemic type 3 reaction, and Arthur's reaction, which is the local type 3 reaction. So serum sickness. This is extremely testable. Serum sickness is the classic immune complex disease. Why the timing matters? It occurs 1 to 2 weeks after exposure to a foreign antigen. 1 to 2 weeks after exposure to a foreign antigen. Why? Because the body needs time to produce enough antibodies. Symptoms begin when immune complexes form and deposit, not immediately at exposure. So classic features we will see are fever, urticaria, arthralgia, lymphadenopathy, proteinuria, low C3 and C4. Again, timing plus low complement is a huge clue. Triggers include drugs like penicillin, monoclonal antibodies, or persistent infections like hepatitis B. These provide antigen that sticks around long enough for antibodies to form immune complexes. Okay, this is about serum sickness. Next, let's talk about Arthur's reaction. This is the localized version. An Arthur's reaction occurs when an antigen is injected intradermally into a pre-sensitized individual who already has circulating IgG. Immune complexes form locally in the skin. Why does pre-sensitized matter? Because circulating IgG is already present. So, immune complexes form immediately at the injection site. This leads to edema, complement activation, fibrinoid necrosis. Fibrinoid necrosis occurs because immune complex mediated inflammation damages small vessel walls. Okay, so classic scenario is strong local reaction after a booster vaccine. So this is the Arthur's reaction. When you compare type 3 with type 2, in type 2, antibodies bind directly to fixed targets on cells or basement membrane. In type 3, antibodies bind soluble antigen. Immune complexes form. Complexes deposit. Complement activates and neutrophils cause injury. So if you see circulating immune complexes, this is type 3. Let's walk through classic exam patterns. Monoclonal antibody therapy, and 10 days later, the patient have fever, urticaria, arthralgia, lymphadenopathy, proteinuria, and low C3-C4. This is serum sickness. Timing plus low complement plus systemic symptoms. The next scenario, a child, 2 weeks after streptococcal throat, having Coca-Cola colored urine, periorbital edema, low complement. This is post-streptococcal glomerulonephritis, immune complexes deposited in glomeruli. Next scenario, after booster vaccination, painful swollen injection site within hours. This is Arthur's reaction, local immune complexes in a pre-sensitized patient. There is young woman with malar rash, photosensitivity, joint pain, proteinuria, and low complement. Okay, we know this is systemic lupus erythematosus, SLE, immune complex deposition in multiple organs. The next one, a child with palpable purpura on legs, abdominal pain, arthralgia after URI, upper respiratory tract infection. This is, of course, IgA vasculitis, immune complex small vessel vasculitis. Another scenario is chronic hepatitis B infection causing systemic vasculitis. Think about polyarteritis nodosa, immune complex mediated vascular inflammation. Another one, penicillin. 1 to 2 weeks later, there is fever, urticaria, arthralgia, proteinuria. So it's 1 to 2 weeks later after penicillin. Of course, it is serum sickness-like reaction. Timing is important, okay, and immune complexes. Next one, intradermal antigen injection. In a pre-sensitized patient, there is local edema, fibrinoid necrosis, of course, Arthur's reaction, okay? Okay, let's summarize. If we see immune complexes plus complement plus neutrophils, it's type 3 hypersensitivity reaction. It will show low C3-C4 with immune complex consumption. 1 to 2 weeks after the exposure, it can be serum sickness. If it is a strong local booster reaction, it is Arthur's reaction. Vasculitis with systemic findings, immune complex deposition. So we should repeat this chain in our mind. Antigen plus IgG, immune complexes, and then there is deposition of immune complexes, and which leads to complement activation, then neutrophil recruitment, and then lysosomal enzyme release from neutrophils and causing tissue injury. Okay, that's all for type 3 hypersensitivity reaction. Best of luck. Have a very good day.